We have a massive amount of prescriptions every day. I think it's roughly about 100 a day, 500 a week. And they're not always straightforward. Change of medication, change of quantities, things that hospital have given them.
The important bit that we found out through doing an audit was that prescriptions were coming in one day, and on some occasions the patient wasn't receiving the prescription for a further 5 days. We needed to look at this and make sure that we did as we state we do, which is deliver prescriptions within 48 hours.
What was good about the module was the fact that we were able to get together as a staff team and look at what had been happening, and I think it did make us aware of the roles that various people played in it.
One of the first things we did was collect data to understand what was happening with the prescriptions.
We weren't aware really of what sort of inquiries we were getting and where they were coming from. So we actually had a data collection sheet, and we did a process of collecting that data so that we could look back and see exactly what we were getting and where and what sort of volume we were getting. We also looked at the turnaround times as well by recording when the prescriptions were received and then the time and date they actually left us.
Repeat prescriptions can come into us via a variety of ways: email, faxes, over the telephone, face-to-face. Emailing was one that we really wanted to push. One, because it's safe for them to email us in. It's secure at our end, we don't lose them. They don't have to pollute their environment by driving into the practice, and we really wanted to push that. So we've pushed it on our website, on our letterheads, everywhere, and it is starting to pay off a little bit. One session we had time out with the whole practice team to look at the prescription process. We did a mapping exercise, and it just built the story of the prescription coming in, reception, how they dealt with it, to then going through to the GP if it needed to be reviewed.
And we found that useful actually, because I don't think GPs realised just how much was involved and where things were coming from.
And likewise, I think the receptionists and nurses had their eyes open to, even though my bit was small, about the number of things I would have to do just to get that prescription reviewed. We identified various points in that flow where patient education was perhaps lacking, and we thought that was an opportunity to see if we couldn't get the patients more on board.
From that we developed a charter which we've got in reception, so patients are aware what we expect from them and what they expect from us.
One of the things that the data collection sheets brought up were the problems that we did have on reception, with people coming into the desk and demanding medication there and then.
As GPs, we were getting an awful lot of interruptions. Some of those were necessary, but a significant proportion were not clinically urgent requests. One of the things receptionists were finding difficult was judging when a prescription was clinically urgent and when it wasn't. So as GPs, we put our heads together and identified a list of about 4 medicines that probably should be issued urgently. If a medicine that was being requested was not on that list, it almost certainly could wait until later on in the day. We've done an audit which has shown, I think, that the actual number of interruptions is reduced by 50%.
And patients are really understanding when you try and explain to them, because we've got the knowledge now. Before we hadn't got the knowledge.
I expect we're similar to other practices in that our main source of information with regards to assessing our own prescribing is PAC data and information filtered down to us from PCT level about how we are doing with regards to prescribing in specified areas. And I suppose our approach until now has tended to be to look at that. I hope we're in the middle somewhere or nearer the top, and probably take some comfort in that and perhaps not look an awful lot further.
And we have stopped and thought about that really, and acknowledge that maybe that's not good enough and we should be looking at trying to tighten things up and getting to be one of the better practices.
The data from the workshop was useful. It showed us that our most expensive drug that we prescribe is atorvastatin, and when we've actually looked at the NICE guidelines, we realised that we need to switch a lot of the patients from atorvastatin to the more cost-effective statins.
A good number of the partners had a session facilitated by another GP where we were trying to really answer the question of, what defines good prescribing. And it was very difficult to actually answer that easily. There is the kind of the financial aspect and what would be regarded from an external point of reference as good prescribing, but then also we felt there was something about having some satisfaction and pride in the medication review that you had done that was actually much more difficult to measure.
As a result of the workshop that we did, it was identified that the practice needed to look at our specials prescribing. So I volunteered to do that work. Specials are items that aren't licensed, and then they're often, but not always, very expensive as well. So my job was to look at the specials and just make sure that they had been prescribed appropriately and to find out if there was a suitable alternative. So I took the list of patients and had a look, and actually what I found was that most of the specials had been prescribed entirely appropriately. I did identify one group of specials, Hypromelo's single unit preservative-free eye drops, and it turned out that they could actually be prescribed more cheaply and as a non-special by using a particular way of prescribing them. And when I looked at the patients, it did turn out that had already happened. The practice pharmacist had been working on it, but I was able to switch a few more of the patients to the non-special item, which was cheaper. I think it's difficult as a GP because there's so many demands on our time, but there's no doubt that this is the sort of work we should do periodically. You know, it's a very large part of our work, and to be honest, it's going to be monitored more and more over the years. We're going to have to justify our prescribing. We have to prescribe cost effectively.